Good afternoon, everyone, and welcome to our Lunch and Learn session, Interpreting Practice Progress Reports. My name is Linda Silver. I'm the Digital Health and Quality Improvement Officer with Central and Eastern Sydney PHN. And with me today are my colleagues Evelina Kozok from Practice Support and Kayla Waldy from Digital Health. They'll be helping me with your questions today. I'd like to start by acknowledging the Aboriginal and Torres Strait Islander peoples of this nation. I acknowledge the traditional custodians and sovereign people of the land across we all work, and I recognize their continuing connection to land, water, and community, and pay my respect to elders past, present, and emerging. I'd like to extend that respect to any Aboriginal colleagues that are joining us today. Before we start, we'll cover a little bit of housekeeping. So please note that this session will be recorded and will be available on our YouTube channel in a couple of days. Please ensure that you use the Q&A function at the bottom of your screen to submit any questions during the session. And we would really appreciate if you could fill in the evaluation form at the end of the session. We appreciate your feedback, and it will also enable us to issue with attendance certificate. I will now launch the session and speak to the data sets included in the report and how they can be used to help you with your quality improvement activities. Okay. I'm starting with the accreditation page. So this report is based on the de-identified data that you share with us as part of your quarterly PIP QI requirements. You probably use either Pancake or Polar to extract this data and send to us, or in some cases, it's in the form of a JSON file. This report is based on the RACGP active patients at your practice, so patients that have visited at least 3 times in the last 2 years. Indicators are ordered alphabetically, and next to it you can see your practice benchmark for that quarter, which is then compared with the RACGP accreditation target. A green flag means that you have met or exceeded this target. An amber flag means that you are within 10% of the target, and a red flag means that you are below that. So if you are just starting with quality improvement activities, please consider starting with the amber flags. So in my case, my sample practice that would be, maybe I could pick allergies, and seeing that I only need 3% improvement to be on target, looking at my RACGP active patients, I can see that it's roughly 30 patients that I have to improve. And I can consider whether it's feasible in my time frame. So yeah, that could be feasible. I can check the patient records and see perhaps that information is already there in the new patient form, and I can just transfer it manually into the clinical system, or I'll have time to do this opportunistically when these patients present for their next scheduled appointment. Alcohol, BMI, and smoking have an aged filter of 15 and over, which means it's not as easy to ascertain how many patients this relates to when we are doing a quick calculation, what's actually feasible. So it's really helpful if there's someone at the practice who can use Pancake or Polar and generate a patient list. Please remember, if you see a patient list of patients missing an indicator and it's long, we are only aiming for a partial improvement. We are not trying to clear the whole patient list. We are just going for a percentage of that to get us over the target. So it can be sometimes overwhelming if you work at a large practice. With alcohol, the issue when it's missing, it's usually a partial answer. So we need 3 data points. So we need the frequency of alcohol consumption, we need the number of drinks per session, and also the number of sessions where the consumption exceeds 6 units. So it can be sometimes there's a partial answer and polar or PenCat evaluated as a fail. BMI has to be recorded every 12 months. And while we see a lot of weight entries that can be done on a regular basis, sometimes the height value doesn't carry over and it's missing and the system can't calculate the BMI. With smoking, patients under 30 years of age need a smoking status recorded annually. Everyone over 30 has to have at least one record since they turned that age. With ethnicity, the issue sometimes can be when we select the answer in the demographics page as not provided or not stated, which again is judged as not recorded. With family and social history, you can either use the coded drop-down menus, but if it's not appropriate, please use the free text box. The system will still pick up on entry being added and it will be considered a pass, but none of that data that you enter will leave your system. There are a couple of considerations here. So if you are a practice that offers allied health services, such as psychologist on site, or perhaps you do skin checks, your statistics here will not be as accurate because the system actually can pick up on regular patients that only see your psychologist. And of course, you wouldn't be collecting this type of data set about them. So please keep it in mind when you're looking at your benchmarks. Also, if you see a lot of elderly patients at your practice or you service residential aged care homes, again, your indicators can be lower. So in case of the aged care homes, that's because the doctor would probably keep those records in the aged care software. If you run a really large practice, any improvement you do will probably take a long time to show up. That's because for you, improving for by 2 or 3% might mean hundreds of patients. So the data can lag behind, and it's possible that you will not see it in the next report or sometimes even the report after. But that's why it's important to document your quality improvement activities because the number of patients can be calculated that you've updated anyway, even when the percentage actually is out of reach. And that can also sometimes be because your practice is growing. So looking at the RACGP active patient number and comparing it with the previous report number can be helpful. All of these things influence whether you can see improvement in the report or not. Okay, moving on. Now we are moving on to quality improvement measures. So these clinical measures are displayed as line charts. The orange line shows your practice progress across the last 5 quarters, so 15 months. And the blue dotted line is the average performance of all practices in our region combined. So on this page, we are looking at type 1 and type 2 diabetic patients who have had the HbA1c result recorded in the last 12 months, which is a blood glucose test used to monitor diabetic patients. And on the far right, the chart shows us a combined type 1 and type 2 diabetic patients with a blood pressure recorded in the last 6 months. So when we are trying to pick an activity, looking at, let's say, my type 1 percentage, I'm at 57% at the moment. I can have a look at the patient ratio at the bottom, which actually tells me that what it means is that 4 out of 7 patients who have type 1 diabetes has HbA1c recorded. So when we talked about previously about starting at an easy place, so this could be it, because I can determine that maybe I can review those 3 patient files and see if the pathology results are actually sitting there, a copy from the endocrinologist, and all I have to do to improve is to enter them manually in the system. Or perhaps I can look at the My Health record for these patients and download those results that way, and that would possibly, I can aim for 100%. With my type 2 diabetic patients, like my patient cohort is much larger. I have 133 patients. So for me, the approach will be just utilizing the usual preventative health reminder methods that I established at the practice. And because my blood pressure benchmark this quarter is only 27%, these two measures can be combined into one activity and covered at the same visit. I would like you to notice a couple of things here. So when we look at the trajectory of your data, let's say type 1 diabetes, it's going from 70% to 33, then back to 57 without any involvement or influence. So that's what we could consider a natural variance. So that could be just a natural ebb and flow of your data. And you can consider whether you want to make it your priority or if that can be left alone for a while. On the other hand, when we look at the blood pressure, we can see that it has been consistently dropping over the last 4 quarters from 79 all the way to 27. That's what we would call a trend. So that's something that will most likely not improve unless you do a focused activity. And what's the right activity for the quarter will depend on how much protective time you have to focus on quality improvement and what other resources you have available. How big is your quality improvement team? So if you choose to, let's say, tackle the blood pressure, a good approach could be to open 5 to 10 patients that are missing blood pressure and see if you can see a pattern. Maybe you can form a hypothesis what could be happening, and it can lead you to a quality improvement change idea. So perhaps here what's happening is that a new GP joined the practice and they use the software differently. They put blood pressure in the progress notes and not in the coded observation field. So we covered, so there's the natural variance and versus the trend, and also that you can consider like forming a hypothesis before you choose what's the right activity. I will now move on to another measure. So here we are looking at regular patients who have had a flu vaccine in the last 15 months at your practice. So, but we are only looking at the vulnerable population cohorts, so people 65 and over, patients with diabetes, and also patients who are 15 and over and have a COPD. So we can see, again, natural variance in action here, because we do expect that there would be a spike in our performance around May, July. So if we try to plan our goal for this flu season vaccination campaign, we can look at how we tracked last year, Q3 2024. So in my sample practice, I'm at 45% at that point in time, and now I'm at 35. So what I could do is I could say, well, I would like to at least match or maybe slightly exceed my target this year. And for me, that would mean improving by 10%, which if I look at my total number of patients over 65, that's 352. So yeah, I would have to reach at least 35 patients in this age group with my flu vaccine campaign. When we look at the patients with diabetes, so this can be probably combined in a same consultation if you get them in for HbA1c and blood pressure, and this would increase organically through those encounters. Maybe end of May, beginning of June, you'll be looking at the patients that are in the hesitant group that haven't presented yet to have the annual vaccine. So what you can do before you reach out to them is to actually do a data completeness quality improvement activity and take advantage of the Australian Immunisation Register being integrated in your software. And you can easily download vaccines given elsewhere to your local record. It's just a matter of highlighting the vaccine and right-click and save. And that can also help boost your benchmark even before the rest of the patients come through, thanks to your reminder. We will be sending you the resource how to do this after the webinar, together with a really helpful immunization checklist that can help you plan your this year's flu vaccine campaign. Before we move on, for the users of best practice, please ensure that you upgrade your system to software named Spectra before the end of February. Otherwise, you will not be able to upload anything to the Australian Immunisation Register from the 1st of March. Okay, so the last data set we look at is around chronic cardiovascular disease risk and cervical screening. So the chart on the left shows us the number of regular patients, the age of 45 to 74, who have all information on file that's necessary to calculate the absolute cardiovascular disease risk. So apart from the date of birth and sex, what they need to have on file is also their smoking status, diabetes diagnosis, or at least a screening test for diabetes, which could be a glucose test or HbA1c. They also have to have their systolic blood pressure recorded in the last 2 years, and cholesterol and HLD levels recorded in the last 5 years. So as you can see, that's this could be considered the most challenging quality improvement measure to improve, because you need so many data points to collect. So when I'm looking at my sample practice, I can see that it's tracking really nicely upwards. There is like a consistent upward trend. This usually doesn't happen without a quality improvement activity. It would be really hard to get it to those numbers without a plan and a PDSA. So it's safe to assume that this practice is doing something and it's paying off, because this would be a result of a lot of hard work. If you see your data tracking upwards consistently across all indicators, like that usually means that someone is really doing a really good job in the background, probably across all sections, from reception to nurses to doctors. Unlike the downward trend that can happen by itself and because of reasons out of your control, like the growth of the practice, an upward trend is usually a really planned activity. Okay, let's look at cervical screening. So here on the right, we are looking at the number of regular female patients aged 25 to 74 who have had their HPV test result recorded in the last 5 years. In case of my practice, I'm at 20% here. So it's safe to assume that some of these patients had the test done elsewhere. So my first point of call could be the National Cancer Screening Register that is accessible in Medical Director and Best Practice. And I could do, again, a data completeness exercise, and I could manually enter the results, results performed elsewhere, into the software before I reach to the rest of the cohort through my preventative health reminders. Another thing, and that can, if you have an NCSR in your software, but you are low on in your benchmark, that could also mean that the staff needs to be retrained how to use NCSR opportunistically throughout the consultations, because that can also be used when the patient is already consulting, just to fill in the gaps if they don't remember when the last HPV test was performed. And it will grow slower, but it will be considered as a change of process, which is expected to show results a bit slower, as opposed to filling in the gaps where the numbers would jump probably within a few weeks. It all depends whether you have the protected time and staff, and whether the list of patients that are missing the data is long. And sometimes it doesn't make sense, especially with a large practice. It's better to change the process and let the data grow organically over a longer period of time. If you are not integrated with the National Cancer Screening Register, please let us know. We can help you with that. And if you need a further incentive to start using the National Cancer Screening Register, from 1st of July, they'll be adding lung cancer screening data. Currently, it has bowel screening and cervical screening data, but adding lung cancer screening will also open up more opportunities for you to do different kinds of quality improvement. Okay, financial insights. This page is intended as a starting point for discussions about continuity of care and whether your current process is working for that purpose. So we are not trying to ascertain whether you are performing too many or too little care plans and health assessments. It's more about whether there is a support for your process and for your staff, whether your practice nurses are confident and comfortable helping with health assessments and care plans, or if they need upskilling, which is again something we can help with. We have one-on-one support on the practice level, but also lots of resources and webinars, and we are preparing more this year. So please let us know. So if we look at the top row, that's all about care plans. MBS number 721 is the initial care plan, and we are looking at how many regular patients with a chronic disease have a care plan built in the last 12 months. And then we compare it with not built, which is again a number of patients with a chronic disease that don't have it built within those last 12 months. The next to it is MBS 723, which is a team care arrangement. And the last one is MBS 732, which is a review of the care plan. So the questions here could be whether the number of initial care plans and care plan reviews is where you like it to be, whether they are fairly matched. That would indicate that you are successful at getting those patients in for a review. And because we know that on the 1st of July, things will be changing. It will be called chronic conditions management, and number 723 will be scratched, and number 721 and 732 will be evaluated evenly. This could be a question about whether the number of reviews, whether it would mean any financial implications for your practice going forward. Also, if you are participating in My Medicare, you could ascertain whether all of these patients that have had a care plan in the last 12 months are patients that you would like to enroll in My Medicare with you, because clearly you are their preferred practice, and how to go about that. When it comes to health assessments in the middle row, here we are looking at, first off, regular patients 45 to 49 who have had a health assessment built at your practice in the last 12 months. We are capturing all the MBS item numbers 701 all the way to 707, but we are calculating the potential revenue figure based on the MBS 703 in the brackets. Health assessments for 75 and over can happen every 12 months. Again, like the analysis captures all the appropriate item numbers, but we give the figure based on number 703. The same applies to MBS 715. Okay, moving on to mental health treatment plans. Here we are looking at anyone with an active mental health condition that's been present for 6 months and longer. and who have had a 2715 or 2717 built in the last 12 months. And the estimate is on the lower number, 2715. And the mental health review follows the same logic with the MBS number 2712. When it comes to the column here, not built, there is opportunity for data cleansing exercise before we evaluate this, because a lot of mental health conditions can resolve over time and they have to be made inactive to get a better figure. So what comes to mind is, let's say, insomnia, or it picks up on anxiety. That can also be something that resolves with time. So to get a more accurate figure, who else would benefit from a mental health treatment plan, we recommend that you go through the patient list first and cleanse it. The last one is heart health check, which is directly related to the quality improvement measure on cardiovascular disease risk, because to perform the heart health check, it relies on having that information available to calculate it, to be able to bill MBS 699. So just want to add at the end that before you would approach any of the patients that show up in a not billed category, you would go through your usual process of checking in PRODA to see if they had it billed as elsewhere before you reach out to them. And I'll move on to our last slide. So this slide is intended for practice owners and clinical leads, and to help them with overall planning and strategy for the practice. Please note that the percentages here will not add up to 100%. That's because patients can have one or more chronic diseases or mental health conditions. And it can also tie in back nicely with the discussion about care plans. If there is a group of patients with a particular disease that you would like to reach for continuity of care. Looking at the top 5 mental health conditions, that could be a consideration about if you have a psychologist on site, you could actually check whether the diseases that show up, or mental health conditions that show up at your practice are a good alignment with the specialties, things that they actually treat, or if you have to refer out a lot. Okay, so I'd like to summarize, before we go to questions and answers, I'd like to summarize the message, how to approach the practice progress reports. First of all, your practice is unique and the data doesn't tell the whole story. So please apply your knowledge of your circumstances of your practice to interpret the data. Sometimes it's perfectly okay. Some of your data will be low and there's a perfectly good reason given the nature of your practice. Also, make it easy on yourself and start somewhere where you don't have a long way to go, because chances are that from a short activity, you will learn a lot about your process and your system, and you can apply it then to the more difficult, challenging indicators or measures. Also, consider what you are looking at, whether it's just a trend, whether it's just a natural variance that can be left alone, or whether it's a trend that needs to be addressed. If you can, do a quick exercise and form your hypothesis to help to lead you to the best possible solution. And please document your quality improvement activities, because this report might take a while to pick up on all your hard work, especially if you are dealing with a growing practice or a really busy large practice. I will now invite my colleagues, Kayla and Evelina, with any questions that might have popped up in a Q&A.
Hello, we encourage more questions, so please ask while you have us. One of the questions which I would like to comment is the question about 723 disappearing in July 2025. So please watch the space. We will be talking about it closer to the date. There will be webinars to watch. The idea is that 721 will cover the chronic disease management plan for the patient, and then the patient would be followed up more often with the review. So the patient, the question here is how the patient will be confused. The patient don't really understand the billing behind it anyway, so I don't think anything will change in here for patient, except that we will encourage more follow-up visits. So 732, maybe the price will be slightly upper, and it will be encouraged to book more reviews for the patients. It is connected with My Medicare reform, and we in Sydney Health Weekly publish the articles how to help you now to prepare for that with the small QI quality improvement activities. So that's, I hope that answered the question.
Thank you, Evelina. I can see a question here. What is Spectra? So that was in relation to best practice software users. They released a major update that relates to the Australian Immunisation Register. So everyone, it's a compulsory update before the 1st of March. The version is called Spectra. Now you are probably on ORCID.
And you asked me if you can watch this webinar later. Yes, it is recorded and it will be published on our YouTube channel.
Yes, yeah. I will send a summary of all the points I covered. So you will not be getting these slides, but you will get a summary of everything we covered in the session together with resources on immunization and probably health assessments and how to document your quality improvement. It looks like all the other questions have been answered during this session. So if there are no further questions, I'd like to thank you everyone for joining us today. And thank you to my team, Evelina and Kayla, for supporting me. And if you can please take a moment to complete the online survey that will pop up in your web browser, that would be much appreciated. We always appreciate your feedback, and we look forward to seeing you online soon. Thank you.